Ladies and gentlemen, this is the operator. Today's conference is scheduled to begin momentarily. Until that time, your lines will again be placed on music hold. Thank you for your patience. Good afternoon. My name is Sarah, and I will be your conference operator today. At this time, I would like to welcome everyone to the Connect and Explore webinar. All lines have been placed on mute to prevent any background noise. For those of you on the phone, if you should need assistance during the call, please press *0 on your telephone keypad, and an operator will come back to assist you. Thank you. Elaine Arkin, you may begin your conference.
Thank you so much, Sarah. Again, this is Elaine Arkin with the NCCOR Coordinating Center, and I'll be moderating this call today. Welcome to everyone. Thank you so much for taking the time to join us. We think this is going to be a great conversation, and so we hope you enjoy it as well. For today's webinar, we have two spotlights. The first one, catalyzing healthcare investment in healthier food systems for community health. And the second is developing a logic model for clinical community engagement. So following the two spotlights, we'll have, it's called a one-on-one session. That's our question and answer opportunity with the four speakers. And then at the end of the webinar, we'll share incoming NCCOR events. Now, if you have a question for our speakers anytime during the presentation, please don't hesitate to write it in the chat box on the right side of your screen, just where the arrow is pointing. And if you need technical assistance at any time, please let us know using that same chat box. We'll be monitoring that. If you're having trouble logging into the webinar but can hear us on the phone, please email us at NCCOR, NCCOR, at FHI360.org. And we'll work with you to resolve the problem and get you on the webinar. Finally, one more important technical note. If you've decided to listen to our webinar using your computer speakers, please turn down or mute your computer microphone. It'll greatly reduce the potential for background noise. Thank you so much. Now, we'll also be live tweeting during today's webinar. If you're on Twitter or other social media, we encourage you to join us by using the hashtag ConnectExplore and following the Twitter handle at NCCOR. Our speakers today, we have four speakers, are Emma Sirois, Susan Bridle-Fitzpatrick, Brook Belay, and Daniel Kidder. Starting with Emma. Emma is the Associate Director of Healthy Food and Healthcare Program at Healthcare Without Harm. And Susan is a Senior Researcher with the Healthy Food and Healthcare Program at Healthcare Without Harm. Brook is a Medical Officer in the Obesity Prevention and Control Branch in the Division of Nutrition, Physical Activity, and Nutrition at CDC. And Dan is a health scientist with the Program Performance and Evaluation Office with the Office of the Director at CDC. Now, to start things off, we'd like to open with a brief poll, just one question. You can answer directly on your screen. And that question is coming up right here. Did you attend or view either of the previous webinars on evaluating healthcare community collaborations that were held in June and September? This will give us an idea of your background on this topic. Okay, so speakers, that'll give you some idea. And thank you to all the folks joining us now who were not on the previous webinars. So if we lose that poll, if we can lose in the poll, thank you. I'd like to turn it over to Emma and Susan for our first spotlight segment, again, on catalyzing healthcare investment in healthier food systems for community health.
Great. Thank you, Susan. This is Emma, and I just want to say good morning to everyone. I'm going to start by describing who we are and how we approach our work, and then I'll turn it over to my colleague Susan to share one of our current research projects. So Healthcare Without Harm was founded 20 years ago with a mission to transform the healthcare sector worldwide so that without compromising patient safety or care, so that it becomes ecologically sustainable and a leading advocate for environmental health and justice. In 2005, we launched our Healthy Food and Healthcare program to harness the purchasing power and health expertise of the healthcare sector to advance the development of healthy and sustainable food systems. We now work with a national network of over 1,000 hospitals and many more health professionals through our national programming, our regional demonstration projects, and with the hospital members of our sister organization, Practice Green Health. We use an environmental nutrition framework, which holds that healthy food must be defined not only by nutritional quality, but equally by a food system that is economically viable, environmentally sustainable, and supportive of human dignity and justice. Our definition of healthy food therefore takes into account the whole system, from production to processing to distribution to consumption, and the resulting impacts on public and environmental health throughout. Healthcare institutions are anchors in their communities. They are rooted in place. They hold significant investments in real estate and social capital. They purchase large amounts of products and services, and they are among the largest employers in their communities. They are therefore in a position to influence the social, economic, and environmental determinants of health in their communities. This slide illustrates several opportunities and leverage points that our program is focused on to promote healthy, resilient food systems for community health, including hospital food purchasing, hospital community benefits programs, and other programs that improve the food environments and increase healthy food access on their campuses for patients, staff, and visitors. Today, we will be sharing in greater depth the work that we are currently doing to assess the models and opportunities for community benefit programs. But before we go there, we wanted to illustrate that these leverage points of the previous slide converge in our new Resilient Communities initiative, where we realize the impact an anchor institution can have on the health of their communities when they layer their programming and they coordinate outcome targets and evaluation. One current project that we're working on in the Bay Area, Anchors for Resilient Communities, is working with other local anchors, so hospitals, schools, and universities, to leverage their assets and capacities to address social determinants of health in their communities. One example of this collaboration so far is that they're working on the development of a local food processing center, which will create local jobs to make prepared meals using locally sourced ingredients from local producers, which are then sold to these local institutions for their food service. These anchors are utilizing their volume purchasing and other investment strategies to support this enterprise, and they have developed a rigorous criteria for evaluating the impact on community health and wealth that results. So now I would like to turn it over to Susan to discuss several research projects that Healthcare Without Harm currently has underway to understand the landscape of hospital community benefit programs supporting healthy food access, healthier food systems, and reducing risk of diet-related disease. Susan?
Great. Thank you, Emma, and thank you all for participating in this webinar. It's a pleasure to be here. As Emma described, the Healthy Food and Healthcare program has begun to work with hospital community benefit programming as one of the prongs of our engagement with hospitals to promote healthy food access and healthier food environments. I'll start with a little background on hospital community benefit for those of you who are not familiar with it. Community benefit programs have been required for nonprofit hospitals to justify and maintain their tax-exempt status since 1969. The previous focus for nonprofit hospital community benefit was support for health care access for indigent and uninsured populations. Several provisions of the Affordable Care Act sought to promote an important shift in focus for the U.S. healthcare community, from treating sickness and disease to a greater focus on prevention and promoting wellness. Recent changes under the Affordable Care Act to IRS regulations governing the community benefit obligations of tax-exempt hospitals have expanded the types of activities generally approved under the community benefit standard. There is now more opportunity for hospitals to collaborate with other stakeholders to implement community health improvement plans that address some of the social determinants of health. New language states that hospitals should look beyond a narrow focus on access to care to the need to prevent illness, ensure adequate nutrition, or to address social, behavioral, and economic factors that influence health in the community. And the slides are jumping around a little. Okay, I think that this is where we want to be now. There are several key elements of hospital community benefit practice. First, a community health needs assessment must be completed every 3 years. Data is collected and reviewed to identify the priority health concerns in the community, and priority health needs are identified. Once priority health needs have been identified, facilities develop an implementation strategy to address these needs. Each year, facilities also submit community benefit reports, and in these reports you will typically find an overview of the priority health needs targeted, the programs and activities to address these needs that have been adopted, information about how the community benefit programs are being evaluated, and how program evaluation will inform revisions to program design and implementation. A key question for many people working in community benefit is, what counts as community benefit? To qualify as a reportable community benefit activity, a program or activity must respond to a demonstrated health-related community need and seek to address at least one community benefit objective. These are to improve access to health services, enhance public health, advance knowledge through education or research, or to relieve or reduce a health burden of government. The IRS does not mandate facilities to spend a particular portion of their revenues on community benefit activities, and in fact, a very small proportion of total operating expense is actually directed to community health improvement activities. In 2014, there we go. In 2014, Healthcare Without Harm conducted research in Massachusetts looking at the ways in which hospitals are using this new community benefit opportunity to address healthy food access and healthy food environments as a strategy to prevent obesity and manage diet-related diseases. The study analyzed community health needs assessments, or CHNAs, and community benefit reports, and conducted interviews with 11 hospital facilities throughout the state. All of the facilities studied had identified one or more chronic diet-related disease as a priority health issue. The study examined whether hospitals were incorporating diet and food access in their CHNAs, what types of food access and nutrition community benefit interventions hospitals were engaged in and how those programs were carried out, and how they were evaluating the impact of healthy food access programs. This slide illustrates the kinds of program evaluation that hospitals were conducting. While a few of the facilities assessed BMI and blood cholesterol, or dietary behaviors before and after the intervention in order to assess the impact on health behaviors or health outcomes, the majority of the programs were assessed using program implementation or process measures, such as number of program participants or number of meals served. Community benefit directors stated that program evaluation was one of the most challenging areas of their work. Some of the challenges they identified for more effective program evaluation were cost, time, and difficulty in designing evaluation strategies that could isolate the impact of a single initiative. The Massachusetts study was the impetus for a national project that Healthcare Without Harm is now undertaking with support from the Robert Wood Johnson Foundation. This research has several parts: a national survey, in-depth interviews with key informants, and a set of case studies. Key study questions across these mixed methods include: how are assessment of the community food environment, food access, and diet-related disease included in CHNAs? What food-related agencies and community groups are collaborating in the CHNA process and in implementation strategies? What kinds of community benefit initiatives to address obesity, healthy food access, and diet-related disease are out there? And how are these programs being evaluated? And for us, a particular focus is what are facilitators and obstacles to community benefit investment in initiatives to promote healthier food environments, including initiatives with food system sustainability objectives. So a little bit more about the research which is currently underway, that we're deep in the midst of right now. Our survey is currently in the field, and the survey will be closed at the end of November. The survey was sent to a national random sample of about 950 private tax-exempt hospitals throughout the U.S. In addition, we're doing about 90 in-depth interviews with key informants. Hospital community benefit directors are the largest group of key informants, but we're also interviewing public health officials who are involved in collaborative CHNA processes with hospitals, CHNA consultants, and hospital associations. And we have begun to conduct these interviews now as well. And then case studies. We will develop a set of case studies on programs that support healthy food access and healthier food environments and seek to reduce risk of obesity and diet-related disease. These will provide examples and kind of a roadmap highlighting lessons learned and best practices for promoting health equity, program design, program implementation, establishing community partnerships, achieving sustainable financing, and program evaluation. Today I will present a few interesting preliminary findings from the first 99 survey respondents to just give you a snapshot of some of the interesting findings that are coming out of this research. Here in this slide, we see what kinds of roles or groups are represented on CHNA committees. Notable here is that organizations involved in emergency food provision are represented on about a third of CHNA committees, and we see other food access organizations also playing a role on these committees. Here we see the percent of hospitals that report having 0, 1, 2, or 3 food access, obesity, or diet-related disease community benefit programs. More than 1/3 report having 1 program, while 28% report having 3 community benefit programs targeting these issues. Community benefit programming to address obesity and diet-related disease are among the most common types of community benefit programs. Here we see the percent of reported community benefit programs targeting different health needs. 74% target prevention or treatment of obesity, 72% target prevention or treatment of diet-related disease, such as diabetes or cardiovascular disease, and 41% target improving food security or healthy food access. Here we see the percent of programs that are managed by hospital staff versus managed by external organizations. Nearly 75% are managed in-house by hospitals, while about 25% are run by community organizations. Here we see the percent of community benefit programs in which food-related organizations are a partner. Organizations for emergency food provision, such as food pantries and soup kitchens, supplemental meal provision, such as Meals on Wheels, and healthy food access, such as farmers markets, were the most common food organization partners. And here partnership can include providing non-cash support, such as staff time, materials, or meeting space for a program, or providing financial or grant support to a program. And then a further level of involvement would be having a formal partnership or a binding agreement. Here we see the proportion of food access community benefit programs that are located in counties of different prevalence of diet-related health issues. There seems to be a pattern of a greater proportion of community benefit programs targeting food access in counties of higher food insecurity, as identified by proportion of population using SNAP benefits. And this is what we would expect to see, a higher proportion of programs addressing food insecurity and food access in areas of higher food insecurity. From this initial analysis, we do not see a similar pattern with diabetes prevalence or obesity prevalence. That is, we do not see a higher proportion of food access programs in areas of higher prevalence of diabetes or obesity compared to areas of lesser prevalence. Here we see the evaluation methods that respondents reported using to evaluate their community benefit programs. 79% reported using a measurement of program participants, counting the number of participants. 28% reported evaluating other program implementation or process measures, such as meals served, pounds of food distributed, etc. 44% used health knowledge surveys. 38% used bioindicators such as BMI. And again, this is from this initial analysis of our survey. We are also beginning to do in-depth interviews, and from these initial interviews, we are finding again that program evaluation is one of the biggest challenges for community benefit professionals. A key goal for this project is to promote a common evaluation framework and common indicators for different types of programs. This can enable programs to aggregate their results and gain a better understanding of what works and why. And currently, there is a gap for some health systems that do not have the capacity or expertise to conduct good program evaluation. Evaluation frameworks that identify short and long-term outcomes and practical measurement methods are really needed. This list indicates some community food program types that we are focusing on to take a closer look at, particularly in the case studies. You'll see that these span from individual level interventions to those that intervene at the community level or at the level of policy and systems. So we're very excited about this research. We really look forward to sharing the complete findings of this national research study and our recommendations with the NCCOR community and other learning communities in 2017. And I'll hand it back to you, Emma.
Thank you, Susan. We just wanted to wrap up by describing the activities that will follow on this research, and Susan has described many of those. But just to summarize, Healthcare Without Harm will be releasing a report with the research findings and recommendations in the fall of 2017. We will be using the information that we gather through the research to develop a set of resources or a toolkit, and this will include the case studies mentioned as well as some primers and issue briefs and guidance for program development and program evaluation. We plan to release that toolkit in the winter of 2017-2018. And then following that in 2018, we will be offering a series of learning and networking forums. We anticipate webinars, a national conference, and regional meetings so that we can share the findings and the resources, but also strengthen the collaboration and build a community of practice to support a wider spread use of these identified best strategies. So we look forward to sharing our process as we go and additional findings and recommendations and resources with the NCCOR community. And thank you so much for having us here today.
Thank you so much, Emma and Susan. That's just really fascinating. And just a reminder to everyone who is with us today, if you have a question for Emma or Susan, please add it to the chat box. And as you can see in the chat box, we will be posting both the slides and a recording of this, and it usually takes a few days. Also, Emma and Susan, we hope that you'll come back and join us for another webinar when this report comes out.
We would love to.
Okay, so moving right along to Brook and Daniel on developing a logic model for clinical community engagement. I'd like to turn it over to you.
Great, thank you. My name is Brook Belay, and as introduced earlier, I'm with the Centers for Disease Control and Prevention. Dan and I will sort of be presenting to you how we've sort of worked with NCCOR this past year in this area of evaluating clinical and community engagement models. In regards to how all of this was developed, this particular workshop, as you've noted, there were 2 previous webinars, and this is the 3rd webinar in a series on this topic of evaluating these engagement models. The original workshop took place in November of 2015. There were many participants, including American Heart Association, Boston Children's, the Greater Rochester Health Foundation, Healthcare Without Harm, Health Partners, and many more. The panelists and the group came together very nicely to look very closely at how healthcare and community engagement programs have been evolving over these past few years, but specifically asking the question, to what degree have they been evaluated? And as these past webinars have shown, that's really what we've been looking at. So moving right along, if we were to ask specifically what were the workshop aims, they were to sort of identify examples of partnerships and engagement, feature aspects of the evaluation of those efforts, specifically, for example, facilitators and barriers, and then look at where there have been gaps in the evaluation of those efforts. And then finally, to try and develop some opportunities and recommendations to promote evaluation strategies and metrics for these models. The workshop products were twofold, if you will. One was to develop a white paper summarizing the insights and proceedings from those panelists and their discussions almost exactly a year ago now. That white paper was released about 2 weeks ago. It is on the NCCOR website. And we hope that in addition to these webinars that folks will find that white paper helpful and useful in sort of guiding their thoughts. Another important output has been to try and share a sample logic model and set of metrics that folks could use as a starting ground for really critically thinking about their evaluation strategy. We'll be talking a bit more about that in just a few minutes. But as part of that workshop, Dan very kindly sort of led the group on the second day of that workshop in trying to develop those logic model and metrics. And so I'll hand it over to Dan now so he could talk to us about that.
Great. Thanks, Brook. I'm Dan Kidder. I'm in the CDC Office of the Director, and I work in the evaluation unit here. And I want to give a brief primer today on logic models or a program roadmap and why we think these are important for any program. I'm going to go relatively quickly through this information so that we have time for Brook to talk about the logic model that came from this workshop. So why would you want to develop a logic model or a program description? I'm going to talk a little bit about the importance of showing impact, creating this roadmap for your program, and how this roadmap helps you identify what your impact is and work to refine the efforts to improve the things that you're doing. And talk about a little bit, Brook will get into some of the indicators of success that come out of this too. So we're really fortunate that our CDC director is really emphasizes the importance of having metrics and showing what we're doing. This is important for a number of reasons, including getting funding, which we all know is super important for the work that we do. And it helps us, here I highlighted a few things. He says it's important to allow us to prioritize, to sustain it, and to improve it if it's not. And to get to this basic question of how can we have this maximum health impact. He's talked about this several times, so here's another quote from him, and I really want to focus on this last one, that we really want to answer this very important question, the most important question of so what? We want to avoid being like these wolves in this cartoon, which is the standard evaluation cartoon. We've got a whole pack of wolves that are howling at the moon. Two in the back are saying, my question is, are we making an impact? We want to not be those wolves. So how do we do that? Well, the context is challenging in public health, isn't it? We all know that programs are very complex. There is often no magic pill for the things that we deal with, and we have to understand and deal with this contextual environment that we're working in. And that makes it really challenging to link your program activities, the things that you're doing, and the impact that you're trying to have on this. So you need to have this chain of events and show what it is that you're doing, identify and measure things along that chain so that you can identify early outcomes that may indicate a problem. So 6 things from our perspective that every program needs to know. The big need to which you're contributing. Public health is often decreases in morbidity and mortality related to X or something similar to that. And then creating this basic roadmap of what do we do and so what, the why do we care, which leads to contributing to this big need. Then along that chain of events of what and so what and the need, what is your accountable outcome? How far down that chain of events do you expect to get with minimal funding, with lots of funding, et cetera? And then along with that, now that you've identified the outcome that you're trying to reach, what are the short-term outcomes that lead to that? And what are your strong activities that are going to lead to these outcomes and hit these dominoes down that are going to lead to achieving your need? And then what do we mean by strong? You need to have sufficient strength to be able to affect those outcomes. And then, of course, there's always contextual factors that help or hobble your efforts. So at CDC, we have this 6-stage program evaluation framework, which has been around for quite some time. And it starts with step 1, engaging stakeholders, and it goes around in this circle. And I don't have time to go into all of these. We do entire day-long courses on the framework and the different steps in the framework. I'm going to focus on this top right corner quadrant here of the describing the program, step 2. And by describing the program, we mean creating this roadmap or logic model. And this is just a graphic depiction of the relationship between what your program is doing, those activities, and the intended effects or outcomes that you expect to occur because of the activities that you're doing. And it shows this if-then relationship among the things, among the program elements. So if I do this activity, I expect this outcome. And make sure that there's clarity and consensus about the main strategies and activities and intended outcomes. I can't tell you how many programs we deal with where people think, oh yeah, we know exactly what we're doing. We know exactly what it's intended to achieve. You get them in the room and you start laying these out, and it's like, that's not the outcome I thought. So it really helps get people on the same page and figure out a way to move forward And so people get very often don't like the word logic model. So we try to use this term program description, program roadmap, whatever you want to call it, because it's really about describing the things you do and not what it looks like at the end. What is this big need? Who are the target groups that I'm trying to reach with the activities that I'm doing? And then identifying, now that we have those target groups, what are the actions those target groups need to take to achieve these outcomes? Okay, and then what are the things that I need to do in my program, the activities I need to do to meet those outcomes? And then making sure that you have a sound logic or program theory or theory of change, that those activities that you're doing hopefully are not made up out of thin air, but are actually going to achieve the outcomes that you want them to. So what might this look like? This is really just a basic logic model that includes this chain from inputs to long-term outcomes. The key pieces here, from our perspective, are really these yellow boxes, identifying the activities or what the program does, and then getting to this chain of events of these outcomes. These activities are intended to have an effect on something. What is that something in the short term? What is it going to lead to in the intermediate? And what's this long-term outcome or impact that you're trying to achieve, the so what. So this gets from the what, the activities, to the so what. And so there are a number of activities that we did and we can do with programs like in this workshop, where we do this with a lot of programs to just kind of get at least a shell of the things that you're doing and ideas of what you're doing, and then you can refine it along the way, but get something on paper. Once you get that on paper, or then what's the reality check of your logic model? You look at these columns. Are these outcomes plausibly connected to the need, to this big long-term thing that you're trying to achieve? And is there something to drive each outcome? Are our activities there? Are they going to achieve this outcome? Is there another outcome that has to occur before this longer-term outcome is going to happen? If not, you refine it. And you want to, when you're looking at this, that your logic model, once you've created it, to make sure that it doesn't look like these guys. So they've got these formulas on the left side and then the solution on the right side, and some sort of miracle occurs in the middle. And so we want to make sure that we're explicit here in step 2. In your middle part, whatever it is that you're doing, make sure that you're not going to do some simple activity and expect decreases in morbidity and mortality related to obesity. Make sure that it's clear what this chain of events or your theory of change is along the way. So that's a really quick overview of what a logic model is, why we think it's important, and we all know that this showing impact is not easy, but it's critical to programs to have some sort of something down that will show the chain of events that you're expecting to happen, be able to measure those along the way, and revise things to improve our programs, which we know we can always do. No program is perfect. There's always room for improvement. How do we measure that? Make sure that we're doing what we can so that we're achieving that long-term impact. So let me turn it back over to Brook and have him talk about the logic model that came from this workshop.
Great. Thank you, Dan. Thanks for leading us through that and giving us a great review of the roadmap and what we do in that workshop. So the sample logic model that we see here is like Dan described. It's sort of really a very broad checklist to help us start thinking about how can we go about really thinking how can we evaluate our effort so that we can identify what are we doing, how are we doing it, and is it really making a difference. To take a step back, and as evidenced by these webinars, the range of panelists that came to the workshop really were engaged in a lot of very different types of community engagement models. So, for example, anywhere from food access to healthy food sustainability within the community, to weight management programs, to increasing physical activity, such as with Safe Route to School programs. So there's a whole range of these possible models. And so what we tried to do during this workshop was try and just what would be some of the common features that could act as a starting point. And that's what this logic model really tries to get at. At the bottom, we see the contextual factors that come into play. And so, for example, that's the degree of integration between and across sectors, primary care, public health, and so forth. What exactly do some of these environments look like? So, for example, in a primary care setting versus a weight management program, and what are the degree and nature of community resources that are available and that are being shared across sectors? And so that's at the very bottom of your logic model there. And just proceeding very quickly from left to right, we have, of course, our inputs from healthcare. Anywhere from the sort of nature of data systems that are there, which can be invaluable in terms of measuring your impact, the degree and type of provider engagement, your community organizations, who is out there and what exactly are they doing, and then, of course, state and other partners as well that can play very influential roles. And then the second column, of course, we start to look at some of the strategies and activities. And once again, this is a broad logic model. We're calling it a sample logic model. But hopefully it'll provide some utility to folks who are starting out in this area. So what are the activities specifically within your school settings, if that's where you're working, early care and education or healthcare? Which populations are you trying to engage? How are you engaging them? How do you elicit their input? And then what are the policy level levers that you are looking to interact on? And then, of course, we move from our short-term to long-term outcomes. In our short-term outcomes, for example, at the individual family level, we might be looking to decrease unhealthy options or unhealthy choices and increase the healthier ones. Perhaps increase engagement and communication across sectors that impact the individual and the family. And then we also look at, for example, at the provider or the healthcare system level, what's the level of knowledge and skill sets across providers and across the system, and so forth. We can drill down to the community level, self-efficacy and awareness of community programs, and so forth. And then, of course, as we move out to intermediate and long-term outcomes, we start to get at some more enduring impacts that we would be interested in measuring. So, for example, once again, at the individual level, degree of family cohesion and engagement in healthier behaviors, how much and to what degree have those changed, and the quality of care at the healthcare system level. At the community level, we might be interested in tapping into some policy level changes. And then, of course, we're looking at long-term policy change and healthcare outcomes, changes in biometric measures and so forth. And that gives us a very broad sense of what a sample logic model could look like. And we do hope to have an editable Word version of the logic model up on our website, or up on the NCCOR website, rather, so that anyone who's interested can kind of take this as it is now and start working from there rather than recreate everything from scratch. Moving on to sample metrics, these are really once again, a very broad example of what metrics one might be interested in measuring, and these vary, of course, depending on the exact nature of your strategies and what you hope to impact. But they do serve as a basis for identifying your indicators of success. So, for example, at the individual and family level, of course, we're interested in behavior change, but also in body mass index and change in weight, change in fruit and vegetable consumption, so for example, and then you can determine what your measures of success will be based on those different metrics. Some important comorbidities to consider, other health conditions, could really help define your impact, or your collateral impact is another way of looking at it. So that way you can speak to a broad range of stakeholders who could really help support your efforts. At the community and built environment level, an example here that we included is the number of early care and education centers that meet best practices around providing healthier food, for example. And then at the policy level, we could look at the number of wellness policies met, so for example, within a school cafeteria setting. And so that really kind of is sort of what we hope to share with healthcare and community groups who are looking to partner. And when we start to speak about next steps, we hope that some of this information can prove useful to individuals and perhaps even a basis for their starting out. I think oftentimes, evaluation is very difficult. It's also very expensive to undertake, but perhaps thinking about this early on can help groups identify some low-hanging fruits for them to kind of start measuring and assessing impact, and thereby they can kind of build on their own momentum as they move forward. And we hope to support evaluation in that regard and support some innovative solutions. Along the lines of what Emma and Susan mentioned, we do hope to see where there might be gaps in some learning communities and try and support those around weight management programs or helping support increased physical activity at the community level. So those are sort of our next steps that we're looking at, and I think I'll pause there.
Thank you so much, Brooke and Daniel. And this is very helpful. In the chat box, participants will see that the white paper is available online. It contains the logic model. I know it was a little bit hard to see on the screen. And it's not as, the print may be small, but it's very clear. And so I hope you will go there and find it. Because in the workshop that Daniel and Brooke led, what we found was, as Daniel was mentioning, it's not just outcome evaluation, but getting partners together in the very beginning and looking at what they're planning to do together really clarifies that everyone's on the same page. And when you start thinking about what is the potential change or outcome as a result of what you were thinking about doing, it's a great time to find out right then that, oh, maybe that's not going to have as much impact. Maybe we should refine what we're planning to do together. So it's a wonderful partnership tool between healthcare and public health. So please do take a look at the white paper. So we have time for just a few questions. We're having a little bit of trouble, I see, with our screen. As a reminder, if you'd like to ask a question, please, is the chat box operational? There it goes.
Yeah, hey, this is Dan. There's a question in there about metrics. Should I take that one from Thomas?
Sure, yes, and I have a couple of other questions, so please go right ahead, Dan.
Okay. Okay, now my chat box is not opening up. But Thomas asked, in light of program evaluation challenges, is it recommended that most programs begin with a single measurable initiative? I think maybe that's indicator, but just to kind of talk about this is always a challenge. People don't have funds to do evaluation or as much as they need or want. So I think I'm going to give a little bit long-winded answer, but hopefully relatively short. The short answer is, I mean, the answer, I think, is to start somewhere. So the first thing is do this logic model, do something. It's amazing when you get people in the room to just talk about what is it that we do and what are we trying to achieve, that what that chain of events looks like. And then on the left side of that, when you talk about activities, the outputs or the measures that come directly from that are typically pretty easy to measure what it is that you're doing. Some are more complicated, but you can do pretty low-cost things to figure out, are you even implementing this right? Are you implementing it with fidelity? Are the participants or whoever you're reaching getting what they need out of the implementation piece of that? Now, when you get to the outcome side, yes, you're right. Things can be costly. They can be more time-consuming and things like that. And if you don't have a lot of money, I would say, yes, pick one or two things to do, but do something. You'd be amazed at how much that can help you when you're writing grants, when you're doing other things. If you can say, we have a logic model, we have only enough money to measure this. I mean, you probably wouldn't put that in your grant application, but we've measured these things, and here's the success that we have so far. And then we're really encourage people to put in, once you get that and funders see that you're doing evaluation, that you want to expand the evaluation and get further to the right of that logic model, then you can get more funds or more staff or whatever to do those things. So I would say, yes, start somewhere, and work to try and expand as you go along. There's also a lot of people don't think about existing administrative data, which is a big push in government, to use existing data to measure some of these things. Now, sometimes it may not be at a fine enough grain that you can do it in your catchment area or get enough, but it can at least, you can think creatively about some of these things, and there's linking that's going on within data sets that's really showing some useful stuff with existing data. So let me stop there, and I hope that answered your question.
Thank you, Dan. And actually, I would like to ask a question of all four of you, and anyone jump in, thinking about the folks on the line with us today. From your perspectives, I know one of the challenges that we've talked about is really getting healthcare providers interested in not even just an initial interest, but a continuing commitment to connecting to the community. So are there ways that either you have seen happen or you are suggesting through evaluation that we could come out with something, some kind of evaluation data or other evidence of value of that connection that would work for the healthcare sector? Since we're usually looking at the public health side, what are some of the things that this could produce that would convince them it was of value to them, not just meeting an IRS requirement, but really valuable?
I could take a quick stab at that. This is Brooke. Just to echo very loudly what Dan was mentioning, some very quick and easy to find data at the administrative level. Administrative might not even be the best word, but so if you are running a program, you've started out and you've gotten a sense of the folks and the walks of life that they're coming from. You've had so many attendants; they've come from so many different organizations or areas. That's probably very easy data that you didn't realize is very valuable and powerful, but you already have. That can go a long way, I think, in showing interest and value, and then that just sort of, could potentially start a snowball effect where leadership or other people who are interested say, this seems very important, I'd like to help out.
Great. Thank you, Brooke. Anyone else want to chime in on that, the value for the healthcare side? Okay, well, we have a number of other questions. So one here is, any suggested metrics to measure progress towards policy change, recognizing that actual policy change may take a significant amount of time?
So I can see about answering that. I mean, policy evaluation is a very big interest in a lot of places, particularly at states. And again, for this, I don't have specific metrics that sort of depend. But again, I think about what it is that you're trying to achieve. What are the activities that you're doing related to this? And then obviously the end goal is having this policy enacted and widely adopted and things like that. But there are things along that chain of events that, again, you can measure. So if you're trying to get policy change enacted, it's likely that there's a number of steps, and I'm not a policy expert, so I'm just going to make stuff up, and it's probably wrong, but it'll be an example. So, I mean, I'm guessing you're going to meet with people, you're going to get the stakeholders involved, you're going to get some sort of policy written, you're going to try and get legislators on board or whoever it is that's going to pass this policy. So all along that route, you can measure the process measures. What are the outputs? Are we meeting with the right people? Are we getting things? Are we moving things forward? And then obviously the end goal is having this policy, enacted, and that's kind of and then adopted. So it's really, again, I harp on the logic model because I think it's really critical to see what are these chain of events. And if you have this miracle in the middle that is occurring and you're wondering why it's not happening, you don't get this policy enacted. You can kind of look along this and say, what's going on? What do we have measures for? What do we need to change to be able to get this policy in place? So without specifics, that's kind of my general answer, but I have other take.
Thank you, Dan. And I think we have time for one other quick question for Emma and Susan. And that's back on slide 22, where you were sharing information about the percentage of hospitals that are addressing 3 kinds of activities: diet-related diseases, obesity, and food security. Do you have any data for how many hospitals are addressing all 3 of these things?
Susan here. Yeah, I can answer that. So this comes from a survey question that is asking about each of the community benefit activities that are addressing obesity, diet-related disease, or food-related health concerns, to identify which health concerns that they're targeting with those CB initiatives. And so you saw that slide that identified what percent were particularly addressing diet-related disease, obesity, or food security. Of the set in this initial analysis, 43 community benefit programs of 167 in this set were targeting all 3. So this would be a particular community benefit activity that was trying to address all 3 of those health needs with the same activity. And then 42 of 99 hospitals had a particular community benefit program that addressed all 3. So because those questions are basically what it's referring to, a specific community benefit program, most of them will probably target food security or obesity or diet-related disease separately, but some tried to basically feel that program is addressing all 3 of those health concerns. And as I said, 42 of 99 hospitals had at least one CB program that addressed all 3.
Great. Well, thank you so much. I wish we could keep chatting because there's some other good questions, but to all of our participants, we're keeping track of your questions, and we will be posting answers and consultation with our presenters today on NCCOR's website following today's webinar. So we haven't forgotten you. We'll follow up on that. And just quickly before we leave, there are some upcoming events we want you to know about. NCCOR is excited, first of all, to host our second Child Obesity Twitter chat next Tuesday, November 15 at 2 p.m. We hope you'll be able to join us. It's a continuation of this webinar series. Some of the speakers from all 3 webinars in this series will be participating, so it's a great opportunity to continue to ask questions, and you can register for the chat using the link on the right. And in the meantime, first of all, we're very grateful to all 4 of you, Susan and Emma and Brook and Dan, for taking the time today to be with us. Great presentations. And I see there's been a lot of interest in the chat box. This is a terrific opportunity for us to really expand how we're thinking about connecting with healthcare institutions and communities that really need a lot of support. So once again, if you have any questions about NCCOR or any upcoming activities, please email the NCCOR Coordinating Center at ncor@fhi360.org. We webinar and every Connect and Explore webinar will be archived in the next few days on the NCCOR website, which has actually just been refreshed. So if you haven't been there lately, you might want to take a look. To access the webinar, use the top navigation that you can see on this screen and click on webinars. All of the upcoming and archived webinars are displayed there. We hope that you will share with your coworkers and peers what you've seen today, and I encourage them to look at the webinar, and we hope that you all will go to that white paper and learn more about what's been happening. So again, thank you so much to our guest speakers, Emma, Susan, Brooke, and Dan, and to all of you who've taken time to be with us today. Before signing off, just take a quick moment for one more brief survey so that we can see that how your responses can help shape future webinars and make the best use of your time. So we're going to quickly switch over to the feedback form now. You can write your input directly on the screen and hit submit, and we hope you have a great afternoon.